welcome to this incredible opportunity where we're bringing together experts in respective fields of exercise science and cardiology and nutrition. And these are experts in their research and in their fields, and we're trying to bring that research out into the application. And today I have Dr. Meagan Wasfy. Welcome.
Thanks so much, Tennille. I'm really happy to be here and share some insights, answer questions, and sort of pull back the curtain on the female athlete's heart.
Well, and let me just share a little bit more about your bio, because it's really incredible. So you're a sports cardiologist and an echocardiographer. What is an echocardiographer?
Yeah, an echocardiographer, I suppose, is a fancy term for a heart doctor that focuses on imaging. That's ultrasound of the heart, or what's called an echo. And it's relevant to what we'll discuss today, because that's one of the simplest ways, one of the more easy ways to get a sense of what individuals' heart, including athletes' hearts, look like.
Awesome. Okay, so now we understand that. And you do that at Massachusetts General Hospital. Your undergraduate degree, your medical degree, and your master's in public health are all at Harvard, right? And you completed your recidency in cardiology fellowships at the Mass General and Brigham and Women's Hospital in Boston. You are the team cardiologist for the Harvard Athletics and co-medical director to the Boston Athletic Association. So our runners are going to be super excited. We are all in just the right place here for today. You're a member of the American College of Cardiology, Sports and Exercise Cardiology Leadership Council, and vice chair of the ACC Care of Athletic Heart Conference. You have been supported and funded by the National Institute of Health and National Heart, Lung and Blood Institute, the National Football League, and Players Association. The bio goes on, so I'll stop there. Is there anything I'm missing that you wanted really to highlight in who you are and beyond all these professional qualifications that we just shared?
Well, as you can probably tell, there's a strong Boston thread through that. So that means I've run, thousands of miles at this point along the Charles River. Probably most relevant is like someone that studies sport is that, I enjoy endurance sport myself. Sometimes I'm more of an endurance athlete but at my core heart, I'm a runner who dabbles in other endurance sports, either when I'm bored or injured.
Yeah, so we can call you a multi-sport athlete. For all those triathletes, we'll just take you into the multi-sport world.
I do tries whenever a specific girlfriend of mine asks me to do one.
We love those friends. Good. Okay, well, let's get into it, and let's just start really at a high level and say, what are some of the differences that we see in the female athlete conference where I met you in one of your slides, you have females are not just smaller males. And so what is it that we need to understand about the differences between the male and the female heart?
Yeah. Well, I mean, that shouldn't come as any mystery, right? I feel like actually, you could start a talk about any organ system and say females are not just smaller males, right? Because their physiology is intrinsically different circulating levels of different levels of circulating sex hormones. And, most sex-based differences follow on from there. And when I think of it from a cardiology perspective, and then you translate that to, health and safety within sport, as well as performance, you can think of it in sort of one of two big bins. Female and male athletes' hearts and vascular systems themselves have some important differences. And those are interesting to understand, both because we need to know what's normal and not in order to know whether an athlete's heart is healthy or not. And they're also important to know because that helps us understand the differences in physiology better. So the nerdy science side also comes in there. And then the other major way in which male and female athletes differ is with regards to outcomes. And so in the heart realm, that ranges all the way from the really highly impactful, but fortunately rare sudden cardiac arrest and death during sport, which garners a lot of attention. And fortunately, it's rare, but the causes and the incidence of that differ by sex. And then also a couple of important other outcomes within cardiology, most more relevant to the master's population. Cardiovascular diagnoses differ between male and female athletes. So that's sort of overarching things. Like the heart and vascular systems are different to start with. That matters in my care because it helps me understand athletes better. It matters for performance, and it matters to understand the physiology. And then at the end of the day, outcomes differ as well. And that helps guide us with regards to how keeping athletes optimally healthy and safe.
Right. So, okay, I'm going to potentially even ask some dumb questions, but these are questions that I would have. So I have just had, and I'm an athlete, and I've noticed that there's something doesn't feel right in my heart. And I go to a person like yourself, and what is it that, like, it wouldn't, okay, how do I ask this? Would a normal cardiologist understand these? Is this a normal thing for cardiologists to understand the differences between okay, two things, male and female heart, in terms of where you're putting the measures or however that ECG is being measured? Secondly, would they understand, is it common knowledge that among the expertise in cardiology that there's a difference between the athletic heart of a female and a heart of a female, like this, of a like, we'll just put them in normal female? Like, is this something that we need to kind of be positing in our heads, of get to the expert that knows the difference?
I'll unpack that at several different levels. So, I mean, first of all, athletes really enjoy seeing medical practitioners, I think, who understand how their athleticism interdigitates with their care. But for every single, organ system of the body and such, just access to practitioners that are going to be able to engage on that level, sometimes isn't there. But yeah, the optimal pairing is always with someone who understands the unique aspects and challenges of the sport, as well as how that interdigitates in with medical care. I mean, it's something I think that's a perfect niche for me, for example, given the combination of interest in sport and how I've built out my cardiology career. And from like an educational perspective, that's where that work you mentioned with the American College of Cardiology is so important. That's a general organization, and just ascending into the chair position, actually from vice chair to lead the course for the US to educate about sports cardiology and some of these nuanced things. Obviously, you have to have interest to take the course, but we hope by disseminating at that big level that even if you're not someone who puts their, sign out as someone who wants to be seeing athletes, that you still have a working knowledge of some of the key aspects of how their heart may differ from that of someone in the general population. Mm-hmm. So that's for starters. I'd say that deep knowledge is more important in, can be more important in fringe cases, right? So I'll give you a classic one, and I'll use your lead to start. An athlete has a symptom of some sort and seeks cardiology evaluation. It may be they get some simple heart tests, and that would be things like an electrical tracing of the heart, an EKG, or a heart imaging exam, like a heart ultrasound, an echocardiogram. It could be that both of those do just look like that of the general population, and they could be called normal, in which case you're on your way and there's no bumps along the way. Right. You'll start out what the symptom is due to, and there's no missteps along the way. But, if you look at on average, athletes' hearts are different than that of the general population. And you look at some of those differences, they can be misinterpreted as being a heart condition. In general, athletes' hearts are bigger. And so that, unfortunately, at times on the extreme end will overlap with early forms of heart disease, something we call like a heart muscle disorder, like a cardiomyopathy. So there's a risk you get sort of mislabeled as having or there's concern raised that you might have an early form of heart disease, when really that's just normal for you as an athlete. So that's where that nuance comes in. And I'd say, cardiac imagers, especially at large centers and stuff, are aware of this. I don't think there's as much knowledge about, like, if you peel back the onion further, about what you would then expect based upon a whole host of demographic factors. Because as it turns out, athletes' heart will differ based upon sex. We do tend to expect different things based upon race and ethnicity, and have a lot to work to go there, as well as to why those differences exist. Okay. And then also what sport you're practicing. So obviously, a high level endurance athlete, a rower or cyclist heart is going to look different than a golfer's heart, for example. So those nuances are certainly things that are more like in the level of expert care.
Oh, super interesting. Okay. Okay, so now we have covered a little bit about the differences, and you mentioned and you touched upon sudden cardiac arrest or death. I mean, what it is, right? Just flat line, or cardiovascular disease. So I want to unpack those, but before we get there, it's the fear. So here we're aging, right? And this idea of this heart muscle, and we want to keep it going. And as we age, just from also like the societal, like, oh, well, you're getting older, don't work so hard. And yet we know if we want to keep as female athletes and we want to keep our muscle and we want to keep, and all of our athleticism, keep lifting, keep running after our friends, keep going into the races, we want to keep working that heart really hard, but there's still that fear, there's still that cultural thing. So can you help unpack what's real for us? Where do we need to think about this idea?
Yeah. And that is so important, Neil. And I think there are definitely some nuances there when you weave in sort of male versus female athletes and such. And so I'll start by like the hopefully affirming message. I'm sure I'll get a lot of agreement that, exercise is medicine, right? You could probably couldn't meet many people that believe in that more than me. And so we need to be moving our bodies, and we need to be moving our bodies throughout our lifespan in order to remain optimally healthy. And things like how fit you are, for example, which can be a byproduct of exercise, and other people get that more as a giftedness just from their genes. Those kind of things are like your fitness is like one of the most potent prognostic indicators in all of medicine. Look at risk of anything, risk of mortality, that's dying, risk of heart disease, and then cancers are, some are more linked than others. And, that's going to go down the more active you are and the more fit you are. And so that's like we have to always ground ourselves in that before we move on to like, okay, what are the risks of exercise? Because ultimately in my head in clinic, dealing with athletes with cardiovascular conditions, it's always a seesaw where you're sort of trying to weigh the risks and the benefits and figure out where you're going to dial in exercise accordingly. Mm-hmm. And so exercise is medicine. Everyone needs to be moving their bodies. And, if we want to provide in the notes, the thing that I always say to most athletes, though, is that, you don't need to be doing ultra marathons or marathons on average, if we look at populations, to get the most benefits out of exercise. And I have to say, in an athlete community, it's worth saying that, especially obviously my lens is someone's come into clinic with some issue, because sometimes folks just think more is more and more is better, right? And so when you're thinking about activity, the couch potatoes are the most at risk for any form of heart disease, because of their sedentary nature and all that comes with it. You get the most bang for your buck with reducing cardiovascular conditions on average by getting off the couch. Our government, here in the US and the World Health Organization, has a recommendation for around 150 to 300 minutes of moderate exercise. That's walking. Anything your folks you coach are doing counts for double there. This is more vigorous. That's, per week. And then, you get 3 or 5 times that. You just continue to get some returns, though it becomes less over time. For example, with mortality, you can get down to like 40% risk reduction from someone who's truly sedentary. But then beyond that, you don't see more returns. So those doing like 10 times that 150 minutes of moderate exercise a week aren't continuing to see health status improvement. Right. But we have to recognize your clients that you coach, my patients that I see, choose to do those levels of exercise for reasons other than optimizing health, right? The social aspects of exercise can't be understated. The ways that for some individuals exercise helps with their psychology and their mindset and the way they feel they live in their best life is important. And then we also have to recognize for an individual human, we don't know that the curve looks the same, right? So there definitely are those people out there where exercise, in excess of whether government might recommend is what they feel like as a person makes them feel their best or helps with weight management. And so individual biology, you don't know what that curve looks like. So I always like to preface that by saying if I were to draw out a curve for you, again, those at highest risk of heart issues are the sedentary. You get a lot of risk reduction with beginning to exercise, but then it doesn't really go down forever. The more you do. Right. And so, but that doesn't in any way make me want to discourage exercise for people, because I recognize folks over here, and they aren't exercising necessarily to optimize what I'm graphing, which might be a health outcome of a given sort. Does that make sense to start with?
Totally. Absolutely.
And so then we talk about the risks of exercise, and this idea, the term that's used is the idea of the exercise paradox, right? So the paradox, one half of it is what I just described, which is exercise overall lowers your risk for dying and lowers your risk for heart attack, strokes, and all forms of cardiovascular disease. But the paradox is that if you're going to have a cardiac event in particular, your risk is higher during an hour of exercise than a given hour spent resting. Now, still most events happen when you're not exercising, because even our most active patients are not spending more hours a day exercising than resting. But if you think about it like an hour unit of time, that's been well established. These are data, like, for example, looking at joggers in Rhode Island, back to the 1970s, this paradox has been recognized. And that makes total sense, right? Because exercise puts stress on the cardiovascular system. So the adrenaline and all the other things that get released during exercise, they're fuel to the fire if unbeknownst to you, you harbor a cardiovascular or unbeknownst or known to you, you harbor a cardiovascular diagnosis. So that's the paradox. And to say the difficult term, the scary term that, we do ultimately have to look at and examine, those events we term sudden cardiac arrest, which is when the heart goes into a dangerous fast heart rhythm, untreated would result in sudden cardiac death. And one thing we should definitely touch on at some point is just awareness about how we can, improve when there is a bad event like a sudden cardiac arrest, improve survival with that, with the right planning and safety with sport. But focusing on those events and how to prevent them, thinking about in an active population of folks who are out there trying to use lifestyle to do the best they can to improve their health. How do we reduce the risk of those events is something as a field and sports cardiology we are really oriented around.
Absolutely. Okay. So what I want to go, there's so many threads that I want to put in my brain and like keep going. Okay. So tell me, I want to stay on this line just for a little bit longer of what is happening when as you age, your heart rate, we don't get our heart rate as high, and it keeps on dropping and dropping. Is that because the heart is not like it's not as strong, like it's like the force and the contraction? Why is it that our heart rate is dropping as we age and we can't keep, we used to be able to get our heart rate up to here and now it's just not. And that level of, when we talk about zones as coach and trying to, understand and how to get to that high heart rate, it starts to shrink a little bit. Can you just help me understand that?
I think I'll couch that in like, what do we expect to happen even with healthy aging in athletes to the cardiovascular system and performance. And if you take the end product, something we can measure like peak VO2 or VO2 max is like the colloquial term. You could also colloquially call that your fitness. Even if you're highly active, that is going to decline with aging. The way I like to think of it though, is if you are a very active 20-year-old or you're inactive 20-year-old, you're starting your decline, maybe at the end of your 20s. And by the time you're 60 or 70, you can't climb a flight of stairs. Like the fitness you have wouldn't allow you to even climb a flight of stairs. So you started out low and you're just going to go down lower from there without some intervention. Our active athletic patients are starting out hopefully in midlife with a high level of fitness and they are declining. But that means, as they get to later ages, you could think of like you're training in your 50s and 60s so that you can remain, active and able to even just take things we take for granted right now, like do your daily activities when you're a 90-year-old, right? Yeah. But that decline, unfortunately, there are certainly many people out there trying to like figure out how we cannot age. But for now, in 2023, that's what we can expect as an observation. And that's due to aging, not just of the cardiovascular system, but, as a major determinant of exercise performance, that's one thing that it is the major determinant of decline in exercise capacity, as well as, other things that happen peripherally, like a natural tendency for body composition to shift, like less muscle and more fatty tissue. So there's stuff outside of the heart and blood vessels that can help account for that. But the heart and blood vessel system, cardiovascular system aging is a major determinant of that. Mm-hmm. And I think of, I explain to my patients, like heart's like a house. And so you've got windows, doors, walls, you've got an electrical system and you've got the plumbing. And really all three of those age, even with healthy aging. The electrical system is the one that would account for the heart rate that you're describing and the heart decline in peak heart rate with aging that you're describing. And, you could think of that as an electrical system getting older. There's no specific, obviously some people have heart conditions where the heart rate's so slow, they need pacemakers, but even with healthy aging, that decline in peak heart rate is aging of the electrical system of the heart. There's other things that happen as our heart, like the structural parts, I guess the doors, I guess more the walls of the heart, the pumping doors of the heart do get stiffer with age, which limits the amount the heart can like generate the output of the heart. big, young, healthy, compliant heart that stretches out like a water balloon is going to be able to generate more output than even a healthy athlete's heart later on in age. And then I like this analogy because it might translate to another thing you have questions about. I don't like to think of the plumbing of the heart having a natural aging process. The aging process of the plumbing of the heart is cholesterol blockages or atherosclerosis. Those are what cause chest pain when you exercise, or if there's a sudden shift to heart attack. And so in our master's athletes, we orient very strongly around like preventing the things we can do to prevent the aging of the plumbing system of the heart.
Yeah.
I think so much, if you're thinking about the other two systems, like the heart rate part is not declining, is not something we have a remedy for. But as cardiologists writ large, and especially with active athletes who want to remain active, we are very proactive and try to think a lot about how to prevent blockages in the plumbing to the heart, the coronary arteries, as a way to keep people active without symptoms and keep them safe as they age.
Yeah. Okay. So that actually can lead nicely. I mean, what I don't want to forget to ask you is specifically how that you were talking about exercise and how we can do more and more and more, and then that extreme level of exercise and getting into that ultra endurance. So I want to just put a marker there that I want to talk about that type of exercise and the risk factors there, or the lack of, because you were saying it kind of doesn't get better, but does it actually come back up? But before that, I want to tie back into I want to talk about calcium and plaques.
Yeah.
That's what I want to talk about. And understanding how that is something that is the difference between males and females. And maybe you could just explain a little bit like what I'm talking about when I say calcium and plaques and the dislodging and then the sudden cardiac arrest.
Totally. And those all link together. So if we're to tie back to the prior question, because we talked about sudden cardiac arrest and death, when we're oriented around preventing that in athletes, we very much have a different list of conditions we're thinking about in younger athletes. And the breakpoint there in research studies is 35. I mean, it's not a line in the sand, but that's younger than 35 and greater than 35 is sort of how it bins out. We could talk about younger athletes if you care to later. But in older athletes, the leading cause of a sudden cardiac arrest or death during exercise, and it's a common diagnosis, a cardiovascular diagnosis in the general population, are blockages in the heart arteries or coronary artery disease. And so that's the calcium and the plaques, the cholesterol blockages, different terms are used for them, basically.
Right.
And so in the general population and true in athletic populations as well, men throughout midlife are at higher risk of this than females. And the major determinant of that is thought to be the protective effect of female sex hormones through menopause. And so through menopausal age, you've got mainly estrogen, to a lesser extent progesterone, circulating at higher levels. And those are protecting against the laying down of plaques, even if you had the same risk factor background as a male, like same cholesterol, same blood pressure, same blood sugars, those kind of stuff. And so we have that protective effect through menopause. And then you know, not in a moment, but over those couple of years, perimenopause, menopause, postmenopause, are losing those high levels of those protective sex hormones. And around that time, we see inflection in cardiovascular risk factors. So that can be a time, not in everyone, but in some women, where you see cholesterol jump up, blood pressure jump up, a bunch of other things change. And then within the next 10 years after menopause, again, in the general population, we don't have a study in athletes specifically, we see risk of heart attack and coronary artery disease sort of catch up to that of males, such that in older people, women actually are a higher risk of those events than males. So there's a catch-up effect.
Bummer.
Yeah, it is like a bummer. And so it's like a good news, bad news. Through midlife, you know, it's very, very rare to see a 40-year-old woman have a heart attack from traditional cholesterol blockage. There are other niche causes of heart attacks, and we should always respect any symptoms in the chest, no matter what age you are. But that is really, really uncommon. It's still rare in men, but I certainly have, you know, those are patients I see much more commonly. But to the point you made, I think that that is an important sex-based difference with regards to how I counsel about risk with my athletes, recognizing in females, you know, in that 35 through menopausal age are at lower risk than men. If you look at sudden events during exercise, sudden cardiac arrest and death are much more common in men than women across the age spectrum. And part of that could be accounted for by the fact that women have this protective effect through menopause, but it's not actually fully explained by that. There's something else we don't know yet that must be at play, because those rates are very disproportionately higher in male athletes than female athletes. Like at least 5x, and men don't have 5x risk of anything that could be causing these events. So women are protected through menopause. I think the thing I always like to make the point, though, is protected through menopause is in a relative sense. There's no one that's zero risk, right? And that doesn't mean that we are any less proactive when thinking about like management of risk factors, right? And I say that for athletes in general, as well as, female athletes versus male athletes. And so, a common misconception, and I had a day in clinic once that really nailed this down. And I have like 3 patients in the whole busy day, but like a decent concentration of patients all came in wearing Boston Athletic Association race t-shirts of various sorts, right? And so they're sitting in the waiting room, they're wearing their BA race shirt. And, if you just asked a colleague or, someone who didn't think about this all the time to go and say, pick out the high risk people in this waiting room, right? Those ones are going to get passed over, right? Like they're active, they look healthy and athletic. Like if you're playing the odds, they're lower risk. And they are, through other lifestyle habits, they are lower risk of heart attack and stroke than individuals who aren't active. But the lens I see things through is I'm a sports cardiologist. I'm getting all of those. That's my clinic. They're all active and athletic. They're doing all they can with their lifestyle to reduce risk. That doesn't mean I'm going to overlook things like sky high cholesterol, out of control blood pressure, other risk factors, especially if the reason they're so active, as can sometimes be the case, is they look back through generations and everyone has a heart attack at 40, right? Because that's going to carry some risk through to them if it's in their genes. And so not under treating these risk factors just because someone presents as highly healthy is something that's really important. And so you don't, by doing so, you almost let that person who's doing everything right with lifestyle regress back to the general population risk a little bit, in my view.
It's such an important point, because I think that I don't know. I'll just say because I don't want to extend out, but there's almost like a complacency. It's just like, oh, I'm doing all the right things, right? Like I have this athletic body. I'm eating well. I take care of things. I'm, thinking about my sleep and my stress level, and yet I still could be at risk. So let's talk about a little bit of that prevention and thinking about, okay, so exercise, great. Got that. But what are there other things that we can be thinking about in terms of both from a medical, like looking at testing or understanding blood pressure or else other things that you just kind of really want to plug for?
Yep. And I had to say back to your niche interests, these are like especially important around menopause and perimenopause, because we know these risk factors, not in everyone, but on average will accelerate in some people. Like you'll be never have told your cholesterol is high in your life, and then it goes up sort of more abruptly than you would think just with aging. And so these are especially important around perimenopause and menopause. And I think the flip side is everything I'm about to talk about, is improved by exercise, right? And so I also think about that perimenopausal, menopausal population of women. I'm a decade off, but the population of women who are in that phase, even if they're highly motivated to exercise and highly engaged in sport throughout their life, it's a busy phase of life, right? It can be a period of time where activity, for various reasons, work and kids and all the various things that we all have to manage, might take a back seat, but it's like actually precisely the period of time where exercise as medicine is the most important, because exercise is medicine for all the things that could be heading, the wrong direction, basically. Absolutely. And so when I think of management of risk factors, and it is medical management as well as lifestyle management of risk factors, I ticked down a whole host of things. You mentioned a few already. Cholesterol is really, if I could make it number 1 through 5. And we think about bad cholesterol in a couple different bins. The LDL is the typical bad cholesterol. Triglycerides are also bad, but also rarely elevated in highly active individuals. And then novel lipids, such as one called lipoprotein A. And I mentioned that one just because it's one that's actually entirely unaffected by lifestyle, almost entirely unaffected by lifestyle, does inflect a bit at menopause, but otherwise is set by your genes, right? So when you talk about like the why me, I'm doing everything right, you know, it is what it is. If it's high or low, if you're to dichotomize it like that, if it's high, it about doubles whatever your baseline risk is. So measuring those, and you know, again in a young population, this doesn't need to be every year around, you know, using or whatever your country of origins is. Prevention guidelines is plenty good, but measuring them and then also having a thoughtful conversation about what the results mean. And so in younger individuals, a relatively high level of cholesterol may suggest, you know, over the next 10 years, your risk of a heart attack is low. But if you look at that summed over a lifetime, it's high if the cholesterol is not optimal. So having a conversation, I sort of like to frame it as, are we going to be reactive and wait? Or are we going to be proactive? And that's an individual choice for an athlete about which mindset they want to take. I'll tie into, you know, diet, and that's a way other than, you know, medication management that you can impact your cholesterol, presuming you're exercising plenty. Blood pressure is another one. You know, on average, exercise lowers blood pressure, especially in folks where they have a preclusion for it to be high. But high blood pressure is super common. And so even if you do everything right, your blood pressure may go up. And that tends to occur with healthy aging. It's just the blood vessels get stiffer. And so we don't use different cut points for blood pressure in athletes versus non-athletes. And the most important thing there is, you know, if you have a high reading in a doctor's office, to follow up and see if it's actually high in your native environment. What your body cares about is not what it is one moment in the office, but on average, what it's exposed to. You know, while resting is the numbers that we index to. Other risk factors I tick through. So metabolic health is important. It tends to be the least likely to stick out in endurance athletes because exercise is one of the best ways to prevent, for example, prediabetes and diabetes. And so obviously there's some individuals that have type 1 diabetes, in which case their cardiovascular risk needs to be aggressively managed. But if you're not starting off with something like that, it's just a rare diagnosis in a master's population. The exercise itself improves the glucose and sugar uptake of your muscles, which is one of the best ways you can get it out of your bloodstream and keep your blood sugars nice and low.
Absolutely, yeah.
And then, you know, if you think of things that we can ask about, but not necessarily measure, like, you know, in the office, diet is really important. I think that, you know, endurance athletes, if you're incinerating a bunch of calories every day, it does still, and staying trim, it does still matter what the content of that food is. And second to sports and exercise, I love thinking and reading and learning about nutrition. You know, as a cardiologist, I'm pretty moderate because I think we've seen diet science for our health, let alone performance, evolve a lot, even over my career. And so, I mean, I think a North Star that everyone would agree on is avoidance as able of highly processed foods. We need easy to digest glucose for longer endurance efforts. That's not what I'm talking about, but for the rest of the day, quote unquote, junk food. That's where trans fat hides if there are any sources of it left in our food. And we want 0 grams of that on any given daily basis. And so I'll stay quiet other than that, because we may have a speaker on nutrition, and certainly it's a contentious topic. Psychosocial stress is one I think that's underappreciated, but we know sort of quote unquote type A personalities, and those with high levels of stress are at higher risk for cardiovascular disease. Exercise is medicine in that regard, but if it's not doing enough, finding other ways to manage stress is important. Not so common in 2023, but a total avoidance of tobacco of any sort is important as well for rounding out the things that we sort of tick down in clinic. And if you don't ask, you won't know, as well as just a nice survey of all other supplements to make sure there's nothing concerning.
Yeah, I think that last point is really fascinating. I've been doing some reading and just like what's in supplements and really ensuring that you're not taking something. There was just an article by Dr. Jen Gunter on lead in supplements of the Ayurvedic brands that, you know, that's coming from wherever, and there's some thought to, you know, it's just fascinating. So really coming into a good source for your supplements is always.
I should say the one thing I forgot is, you know, family. I do also ask about family history. It's not something you can modify, but getting a sense for like, is there something that runs through your family that it's possible we're not capturing it, right? It might not be that your cholesterol is high and your dad's cholesterol might not have been high and his dad, but if they all had heart attacks at the age of 40, it's likely something, and we're humble, we can't measure everything that crosses through generations that confers increased risk. So that an early history of cardiovascular disease is something that we use to sort of help calibrate that sort of proactive, reactive, how aggressive we'd want to be with the both the counseling about lifestyle, but also the medications we can offer for prevention.
Absolutely. Okay, we have two more things that we really need to touch on before I let you go, if possible. Okay, one is just some things, then maybe these are this first question is not anecdotal, it's in the literature. It's the heart rate palpitations. So in perimenopause, some women experience, they're sitting on the couch, they're totally relaxed, and all of a sudden their heart rate is flying out the window. And is there anything that you can speak to or help us understand? Of course, if that happens, go and see your cardiologist, go and see your sport cardiologist and ensure that it's not something else. But is there any understanding of why that is happening?
Yeah, to my understanding, it's not clearly understood. You can also see that with hormonal shifts in pregnancy. And I mean, first of all, I'd say any palpitation symptom, regardless of age, it is worth bouncing off your doctor. It need not be a cardiologist from the outset. And I have to say, especially folks who are in tune with your body, if you're able to describe what you're feeling, sometimes that gets us 90% of the way to calibrating what are we thinking we might be worried about, right? 10% can usually easily be solved by a wearable monitor that you'd have at home, either something that's prescribed or there's now consumer devices available to actually know what that symptom is. And amongst the cardiovascular conditions I mentioned, beyond the most dreaded one, sudden cardiac arrest, atrial fibrillation is a cause of palpitations that is more common in long-term endurance athletes. It is potentially related to that enlargement of the heart that occurs with exercise. It's certainly much more common in male endurance athletes, and we have evolving data, given its sort of decades and decades of hammering that probably augment risk in groups that have finally found large enough populations of women to study, that risk augments as well, though perhaps not as high as it does in male masters athletes. So that's a first checkbox, is it AFib or not, that I would always encourage. Because though you're mentioning these things happening around perimenopause, AFib is more common in athletes and more common with age. And so it's going to be rare.
All those factors together.
Right. Beyond that, let's say it's a benign cause for heart palpitations, like an occasional extra beat, or it's your own heart, like your normal rhythm, the electrical system's working normally, but your heart rate has gone up. This speaks to the heart, how the heart's not in a concrete box, right? And so it's getting input from everything in the body, right? The same could be said for increases in psychological stress, or sometimes make a person's heart race or cause them to have more extra skip beats. And so I don't actually know, I'll be humble, I don't know what about perimenopause could bring that out, but your whole hormonal physiology is shifting. And we know that can be both month over month, year over year, but also day over day, with sort of the vasomotor symptoms of hot flashes and things like that. And so the heart's subject to all those changes as well.
It's just so amazing. It's just bringing the body back into this holistic. One thing that I'm really interested in for some of my athletes, what they're noticing as a big change is that when they start out their workouts, their heart rates are going, it's like going from 0 to like the engine's revving. And it's really like, they're just like, hold on, I'm just doing an aerobic run here. Like, try to bring it down, body. Like, why are you freaking out? And it's almost like when you start to run, all of a sudden your body will just start sweating, and you're like, it's not even hot out, and your body's like working really hard just to like get rid of the heat. It's like, oh my goodness, I'm going to start working hard. Is there anything linked there of our understanding? Or is it just another thing that we've got to kind of start looking into? Like, why is it that your heart rate is jumping up so high when you initiate your workouts? And it's an obvious change. It's something that is like, they can't buy another heart rate monitor just to validate. They're just like, I have tried 3 heart rate monitors, I've changed the batteries, I don't understand what's going on.
That's where like an observation like yourself, who's so like intimately involved with like the day in and day out of athletes, could prompt a whole research study, because I don't know that observation's been stated out loud before. Like, take people. The way to do this, of course, is to get people before they go through menopause, during, and after, and show the change. It sounds like you've observed that change from experience. And again, it's a nice example of how a couple of different things. The heart subject to all the changes that are going on in the body otherwise, that we can say for sure. And that some of those do specifically impact the cardiovascular system. And so there's nice studies by others that are intriguing to me and not specific to athletes that show, for example, right around that time of menopause, really before menopause, as you're beginning to lose estrogen, that things like the stiffness of your blood vessels start to go up, right? And if we think about what the body has to coordinate together to produce an exercise effort, it has to be so minutely dialed in, right? Or else something feels off, right? That as you're describing, the athletes may also feel off when they're trying to initiate exercise. And so I always, when I take a big step backwards, I marvel at the fact it does it right 99% of the time, right? And you feel good because it's like being at the head of an airplane and you got a lot of things to control. And so we don't actually have a great data to understand what through normal healthy aging, including perimenopause and menopause, happens with exercise capacity. And then also the various components, things like heart rate versus the output of the heart versus the stiffness of the blood vessels and their ability to accommodate more blood flow, how all that shifts and how it shifts on average and how it might vary, right? That not everyone's experience with aging is the same. So there are different sort of subgroups. Yeah. I'll put out there just as a hypothesis, but I'll say, no idea if it's correct, that beyond just the hormonal milieu creating some shifts, that if women are experiencing more, if they're in that phase where they're still bleeding, if they're experiencing more than usual blood loss, it's just a time to make sure you're buffed up as far as your iron stores, because of course any iron deficiency will cause higher heart rates during exercise. Your blood's not got enough oxygen capacity. And then the flip side is that we do know with aging, that it does take longer for the cardiovascular system to warm up. And so not so much heart rate, but if you're starting out at an X minute per mile pace, but the heart pump itself and your blood vessels haven't warmed up. And by that, I mean, gotten themselves augmented. Blood vessels need to relax a little bit to get blood flow to muscles, and they're taking more time to make those adjustments. The only way the body's got to get the output out to those muscles that are already moving at that same pace is to jack up the heart rate. So that's a hypothesis I've got, is that the heart rate's telling you the rest of it needs a little more time to warm up, and you might overcome the symptom by leaving more time to warm up, but no one's proven that. Now you got me thinking about my next study.
Yeah, well, the way that we're dealing with it for those athletes that are finding it, and it's not always, and it's there's a lot of things that we're trying, is definitely just slowing down that warm up for sure, allowing the body to come into it. I'm always okay, maybe 20 minutes isn't enough today. Let's just see, let your body come into it. There's two more things. I know I said two more things, but now we have two more things to cover. You wanted to talk about the safety and to bring that back in and just sort of thinking about how do we be safe as athletes, or things to be aware of. I don't know if there was anything that you wanted to add into that. And the second was just those ultra endurance athletes and that risk factor.
Totally. Well, safety of exercise, you can think about it like two sides of a coin, right? So we've spent some time on one side already, which is prevention and management, identification, prevention and management of the conditions that predispose to these events. Like I mentioned, in masters athletes, we're largely oriented around worrying about coronary plaques, coronary artery disease, heart attack. We talked about the risk factors for that. In younger athletes, it's different set of conditions, mostly things that you can't so much prevent. You're either born with a genetic predisposition for, or your heart has formed a certain way, in utero, and that's different than what a normal heart would look like. Mm-hmm. So there it's more oriented around identifying those conditions, and then, modifying engagement with exercise accordingly, or reducing risk using the therapies we have available. So that's one side of the coin. Things on that side of the coin, like I mentioned, are for example, screening of athletes, and then, risk factor management. But we could have all the resources available, both at every level of sport, and still have cardiac events during exercise. No efforts on that side of the coin are ever going to get events of these scary events down to zero. We have to be humble in that regard. So the flip side, as I alluded to, is being prepared and knowing how to, if when a sudden cardiac arrest occurs, how to react and respond to improve survival. A big picture, we call this emergency action planning. That's like the more appropriate term if you're dealing with a sporting event, whether that's something like I work with the BAA for their running events, including the Boston Marathon, but any organized sporting event. And, but not all, well, most of exercise isn't occurring in those organized settings. Yeah. And so it also involves the athletic community writ large having awareness of how themselves to recognize a sudden cardiac arrest and how to be a bridge till help arrives. So activating and calling emergency services. But what I'm referring to is knowing how to perform hands-only CPR yourself to serve as someone that can serve as a bridge and help save a life until emergency services arrive. I can provide as resources just a few things that I have at my fingertips, an awareness video we did with the Boston Athletic Association, and then a different video that shows what sudden cardiac arrest looks like, because it is a little bit different than people might picture. The way I think of this, the other side of the coin, is that the more our athlete communities are aware of what this looks like and how to respond, it's like our safety net. It's how we improve the health and safety of the whole athlete community. So like athletes caring for athletes, if that makes sense.
I love it. I think it's super cool. So yes, please send that resource and I'll make sure that it goes far and wide. Finally, the ultra curve.
Yes, totally. Well, I drew out a little curve in the sky here. And if I'm being honest, many of the populations, this is risk of mortality or heart disease. It does go down and then really plateaus out. And the funny thing we have seen in the population of people, the amount of training you'd have to do to be an ultra athlete is that numerically the risk does inflect up less than I suggested by the hand there. But that just a nerdy research thing is it's never statistically significant, meaning there are in a population study, there are so few people, even if the cohorts sometimes are 500,000 people in the population, there's so few that are doing 10 times the recommended amount of exercise that it's hard to have that estimate be precise. But we've seen it enough time. These are in cohorts published, back to the 1990s to present day. We've seen this. It's called a reverse J-shape curve often enough that most of us think there's probably something to it. And it's also intuitive, right? Like when you think about dose response, it's always like too little is not enough and too much might be too much, right? Again, this is never it's not meant to be fear mongering. It's not a literature that I use to sort of want to instill fear in those who elect to do those amount of exercise. But to me, it really underscores the extreme importance of not undermanaging risk factors when someone presents as a highly active athletic person. If I'm thinking about that inflection risk may be true, most of the folks who are in ultra endurance world are past the age of 35, and not all of them. But the best thing I can do to protect that population of athletes is not to undermanage those cardiovascular risk factors we just thought about. And though in general exercise is going to lower blood pressure, cholesterol, electing to do those large amount of exercise, the population of people that do that, and I wouldn't consider myself an ultra athlete, but as an athlete, I can see this. There may be some enrichment of risk factors in that population. I mentioned one already, which is you've elected to do this much exercise because you see what happened when folks in prior generations, right? They had heart issues. So you're sort of running away from that risk that you see in prior generations. Some people like to do that amount of exercise because they're looking to get forgiveness for the sins of their early midlife, their 20s and 30s. They were not active and they sort of see the light. They're like, okay, more's got to be better. I got to make up, right? The incineration of calories. So the diet that you have, the amount of calories you have to eat is huge, right? But if those calories are all highly atherogenic, we got to take a hard look at that and figure out with the nutritionist what you can do to tweak that. And then again, you might elect to be using exercise to manage a preclusion to have anxiety and depression and other stress that and exercise is helping manage that, but there might be some residual risk to that being sort of like the way that you're wired to start with. And so I always like to take a deep dive into all of those things. But the fact of the matter is not undermanaging risk factors is the best that we can do. Of all the cardiovascular conditions, that we have studied, it does seem like one that is more common in those who practice huge amount of exercise over decades is that heart rhythm disturbance, the one I referred to called atrial fibrillation. Fortunately, though, that is not a condition that results in sudden cardiac arrest and death. It can limit performance. It can certainly, it can require some management. It produces symptoms during exercise that may make you not feel too good. But I like to think of that as a condition that I have a whole toolbox full of tools to deal with. And so like fear of developing that shouldn't be a reason that someone doesn't exercise the way that they like, even though we do know high amounts of endurance exercise over decades do seem to preclude to it.
Such an amazing, wow. This has been like, I'm speechless. This has been so fantastic. And just what the wealth of information you have just shared with us is just, I'm just eating it up. I can't wait to, and for everybody to have it. Is there anything that we haven't talked about, or that you want to just say or sum up, or to, conclude?
Well, thank you for having me, because I think some of these messages are ones, obviously I can share them with my individual patients and my smaller circles here, but to get them out into the broader endurance athlete community, to me, is a way to extend impact. And so I'm really grateful for the opportunity. I think one point that you raised in the beginning, like how do you find the docs with which you align? I think that that's a really important question. And if listeners have any questions about how to find folks locally that, if they have clinical needs or questions, they can feel free to reach out. And I can also provide you a resource of those within the sort of leadership component of what we do within the United States, which can be a nice starting point. They're spread through all throughout the US, Europe, and Canada, if I remember correctly. Yes.
Yes. Well, it's so fantastic, because we like to point a lot of our athletes in, like the American Menopause Society, like where's the people that have the training, where's the people that will have that, because quite frankly, a lot of the doctors haven't been, if they're coming from a history and they have buckets of experience, but may have not got the training in menopause, they might not have them up to date knowledge.
Similar like alignment, we have like a list, and you could look and see who's including some great individuals up in Canada, including ones I've had the pleasure of training. So that's a resource I'm happy to provide as well. In the end, I think that the take home message is that exercise is healthy, and commend mostly everyone who's listening. I think that is out there checking the box and doing what they need to do to improve their health with their exercise. That doesn't mean any of you ignore symptoms that might, anything above the navel. Make sure you talk those through with your doctor, and your primary care doctor is a great start. You don't need a specialist off the bat. And then that bug in the ear, just to, in thinking about your risk factors, whether they've been raised with you by your doctor or whether you've noted them yourself, just the thought that, by being highly active, let's not take our eye off the ball, not to mix sports puns, and make sure that we are looking at our cardiovascular risk factors, because all that exercise is lowering risk. It doesn't lower risk to zero. We want to keep a whole population of endurance athletes healthy, free of heart disease, doing what they love for as long as possible.
Love it. I'm going to leave it there. Thank you so much.